Welcome to the Explainer. Today, we're basically putting on our detective hats and conducting a full-blown pathological investigation. We're going to get up close and personal with the top 4 metabolic attackers that literally destroy the liver from the inside out. Now, if you're a medical student, a healthcare professional, or just studying for your board exams, you're going to want to pay close attention because we are hitting some incredibly high-yield concepts today. We'll be looking at how totally distinct diseases trigger remarkably similar pathways of destruction, and more importantly, how we can use very specific clues to tell them apart. Let's get into it. So here's our roadmap for the case. We're going to start by examining the battlefield, the hepat lobules. Then we'll interrogate our 4 prime suspects: alcoholic liver disease, non-alcoholic fatty liver disease, toxic and drug-induced hepatitis, and finally, alpha-1 antitrypsin deficiency. Part 1. The battlefield, hepatic lobules. Okay, before we bring in our suspects, we really need to understand the scene of the crime. The liver doesn't just get attacked randomly all at once, right? The damage is highly strategic and localized within these microscopic functional units we call hepatic lobules. Now, a hepatic lobule is divided into 3 functional zones based entirely on its oxygen supply. Zone 1, which is the periportal zone on the outside, gets the most oxygenated blood. That makes it the least sensitive to ischemic injury, though it is very susceptible to viral hepatitis. But as we move inward to Zone 3, the pericentral zone right around the central vein, the oxygenation is extremely poor. And guys, this is a massive buzz point for your exams, because Zone 3 has the absolute poorest oxygenation. It is the single most vulnerable area to metabolic and toxic injuries, as well as ischemia. Keep Zone 3 locked in your mind, because our suspects love to strike there first.
Part 2. Suspect 1. Alcoholic liver disease, or ALD.
So our first suspect is a massive cause of liver disease in Western countries, typically showing up in patients who consume roughly 7 to 8 beers daily. But what's the actual weapon this suspect uses? Well, the oxidation of all that alcohol creates a huge excess of NADH over NAD+. This essentially slams the brakes on mitochondrial fatty acid beta oxidation, leading to a massive, toxic accumulation of fat. The destruction happens in 4 distinct stages. It kicks off with simple hepatic steatosis, which actually develops in about 90% of heavy alcohol users. Now, at this first stage, it's completely asymptomatic, and this is crucial. It's entirely reversible if the patient just stops drinking. But if the assault continues, we move to alcoholic steatohepatitis, where we start seeing actual cell death and inflammation. Next comes alcoholic steatofibrosis, which is where collagen begins to deposit. And finally, this whole fatal cascade ends in alcoholic cirrhosis, which gives you those classic expansile regenerative nodules and bridging fibrosis. And microscopically, this damage is pretty spectacular to see. The hepatocytes actually swell up. They balloon to 2 to 3 times their normal size. The cytoplasm gets all rarefied, which is a classic hallmark of cell death. But within that swollen cell, you'll also spot this strange red globular material accumulating right inside the cytoplasm. If you spend any time looking at pathology, you already know this is a highly tested finding.
Yep, those red globs are Mallory bodies, sometimes called Mallory-Denk bodies. So what are they exactly? They're cytoplasmic inclusions made up of aggregated, misfolded cytokeratin intermediate filaments, specifically CK8 and CK18, along with ubiquitin. Now, while Mallory bodies are absolutely essential and highly characteristic of alcoholic steatohepatitis, it is vital to remember they aren't totally exclusive to it. We're actually going to see them again.
So if the microscopic evidence isn't 100% exclusive, how do we confirm ALD clinically? Well, the magic number here is 2. In alcoholic steatohepatitis, blood tests typically reveal an AST to ALT ratio that is greater than 2. For instance, you might see an AST of 150 and an ALT of 70. This is a super unique clue because most other liver conditions elevate ALT higher than AST. A fun way to remember this is AST stands for alcohol super high. Plus, ALD is very commonly accompanied by macrocytic anemia, meaning the mean corpuscular volume, or MCV, is going to be elevated above normal. Part 3. Suspect 2. Non-alcoholic fatty liver disease, or NAFLT.
Now, this next suspect is an absolute master of disguise. It causes histologic features that perfectly resemble alcoholic liver disease, but it strikes patients who consume little or zero alcohol. Thanks to the rising rates of obesity and metabolic syndrome, NAFLD is actually now the single most common cause of chronic liver disease in the United States. And its progression perfectly mirrors ALD. It evolves from simple fatty liver to the inflammatory stage known as NASH,
then to steatofibrosis, and finally to cryptogenic cirrhosis and even hepatocellular carcinoma. The mechanism of destruction looks exactly the same, which really deepens our diagnostic mystery. What's truly fascinating here is how virtually indistinguishable these two suspects are under a microscope. Both of them begin their attack in that vulnerable, oxygen-deprived area we talked about earlier, zone 3. In both diseases, as fibrosis develops, collagen starts depositing around the central vein and individual hepatocytes. Under a special stain, this creates a highly characteristic perisinusoidal or pericellular pattern known as chicken wire fibrosis. It literally looks like chicken wire wrapping around the cells. The tricky part? You absolutely cannot tell ALD and NAFLD apart just by looking at this chicken wire. So, to resolve the mystery and separate these two suspects, our diagnostic detective has to look at the lab work. And it's a stark rule of contrast. While ALD presents with that classic AST to ALT ratio greater than 2 and macrocytic anemia, NAFLD presents with an AST to ALT ratio that is usually 1.0 or less. In fact, you might be shocked to learn that liver enzymes can be completely normal in up to 78% of NAFLD patients. But wait, if there's no alcohol involved, how does NAFLD actually poison the liver? The most widely supported theory right now is the multiple parallel hits hypothesis. It's a combination attack. First, insulin resistance causes an increased delivery of free fatty acids to the liver where they accumulate as triglycerides. Second, this massive influx of free fatty acids actively damages the mitochondria, impairing beta oxidation and causing free radical cell necrosis. Third, an imbalanced gut microbiome increases lipopolysaccharides or LPS, which triggers the liver's Kupffer cells to unleash inflammation. And fourth, altered adipokines from body fat, specifically a reduction in protective adiponectin and an increase in leptin, promote even further liver fibrosis. It is a very coordinated assault. Part 4. Suspect 3. Toxic and drug-induced hepatitis. Now, you might be surprised to learn that prescription and over-the-counter medications actually account for over 50% of acute liver failure cases annually in the U.S. These chemical attacks can either be predictable and dose-related or completely idiosyncratic. And here's a massive high-yield concept. Different medications leave incredibly distinct patterns of injury on the liver. The most famous one, acetaminophen or Tylenol. In high doses, it causes predictable acute hepatocellular necrosis, specifically in, you guessed it, zone 3. Why? Because that zone is incredibly rich in the metabolic enzymes that convert the drug into its toxic metabolite, but very poor in oxygen to help the cells recover. Other drugs leave totally different fingerprints. NSAIDs and amiodarone can cause macrovesicular steatosis, meaning a single massive fat droplet forms and shoves the cell's nucleus out of the way. Meanwhile, drugs like tetracycline and valproic acid cause microvesicular steatosis, which fills the cytoplasm with tiny little lipid droplets while the nucleus stays perfectly centered. Part 5. Suspect 4. Alpha-1 antitrypsin deficiency. Unlike the others, our final suspect is a rare inside job. It's a genetic condition with a totally fascinating bimodal age distribution. In kids up to 5 years old, it presents as neonatal hepatitis that can progress to cirrhosis. But in adults over 40, it presents as severe lung disease, like panicinarum emphysema alongside liver cirrhosis. To decode this one, we have to look closely at the genetics. The disease is caused by mutations in the SERPINA1 gene. The normal variant is the M allele, but the most common deficiency variant is the PI/ZZ genotype. This genotype features a tiny point mutation that causes the alpha-1 antitrypsin protein to fold incorrectly. And because it's misfolded, it literally cannot be secreted into the blood to go protect the lungs. Instead, these polymerized molecules just sit there, accumulating inside the endoplasmic reticulum of the hepatocytes, creating massive ER stress that triggers cell death, inflammation, and ultimately cirrhosis. So the crucial point is how we actually catch the suspect at the scene. Under a microscope, using a periodic acid Schiff or PAS stain, pathologists look for very characteristic round eosinophilic inclusions sitting right inside the hepatocytes. These inclusions are strongly PAS positive and diastase resistant. If you're studying for the boards, write this down. When you see the buzz phrase PAS positive diastase resistant inclusions, you know exactly what you're looking at. You are looking at polymerized, misfolded alpha-1 antitrypsin physically trapped inside the liver cells. So, we've tracked 4 incredibly different metabolic attackers today. Excess alcohol, metabolic fat and insulin resistance, common drugs like acetaminophen, and genetic misfolding in the SERPINA1 gene. Yet, astoundingly, they all lead down the exact same fatal pathway: zone 3 injury, ballooning degeneration, and that classic chicken wire fibrosis. The liver is an incredibly fragile organ. But remember, early stages like simple steatosis are completely reversible. And that leaves us with a pretty provocative question to ponder. As our understanding of these different metabolic hits grows, can we develop targeted interventions to stop and actually reverse this process before that delicate chicken wire hardens into irreversible nodular cirrhosis? Thank you so much for joining me on this pathological investigation. Keep reviewing these core concepts, and I'll see you in the next explainer.